This is Dr. Mary Chamberlain, and I'm here with Dr. Dennis Juranek at the Centers for Disease Control and Prevention in Atlanta, Georgia. Today is Monday, July 9th, 2018. I'm interviewing Dr. Juranek as part of the Oral History Project, CDC's Early Response to AIDS. Dennis, welcome to the project.
Okay.
Do I have your permission to interview you and to record the interview?
Yes.
Dennis, you arrived at CDC in 1970 as an Epidemic Intelligence Service Officer, or EIS officer. And apart from a year of career development at the London School of Hygiene and Tropical Medicine, your entire 36-year career at CDC was spent in parasitic diseases. That's a pretty remarkable run. You had been at CDC for more than 10 years when the June 5th, 1981 Morbidity and Mortality Weekly Report on pneumocystis carinii pneumonia among homosexual men in Los Angeles was published. And being in the Division of Parasitic Diseases, pneumocystis was one of your bugs, so you and your colleagues were involved in AIDS from the go-get. But before we delve into the details of all of this, let's start with talking a little bit about your background. Can you tell us where you grew up, about your early family life?
I grew up in Colorado Springs, Colorado, the foot of Pikes Peak. Had the mountains to play in on the west and the Great Plains to play in on the east. I was the middle son of three, and my father was a paint contractor. My mother was a electronics technician. She worked assembling motors for Emerson Electric for a long time, and then later soldered circuit boards for Ampex tape recorders used in the phono and recording industry.
And where did you go to college, and what did you study?
I went to college in Fort Collins, Colorado. Got a bachelor's degree in biology there, and then later a doctorate in veterinary medicine from CSU.
So that's Colorado State University?
Colorado State University.
So what or who influenced you to be a veterinarian?
Well, my grandparents and aunt and uncles lived on farms in northeastern Colorado, so I would spend a lot of my summertime with animals down there, develop an interest in those animals. And then did basic biology in college and was accepted to the veterinary school and then studied veterinary medicine.
Now you came to CDC, if I'm correct, immediately after completing your veterinary degree?
That's correct. My senior year had a visitor from CDC by the name of Richard Parker, who was then the head of the zoonoses unit at CDC. And that was my first introduction to CDC and the EIS. He gave a very nice presentation, what the options were, what we could do there. And like most people in my cohort, we were at the time of the Vietnam War, and going to CDC offered an opportunity to fulfill our military obligation by doing something really useful, in my mind, rather than just doing meat inspection or candling eggs in the military. So that was a big stimulus to go, and had no intention of staying at that time, was just going to do my 2 years and get out. And then at the end of my 2 years as an EIS officer, I was offered a career development program in which I was allowed to go to the London School of Tropical Medicine and Hygiene, where I studied medical parasitology, got a master's degree in medical parasitology there, and then came back to CDC. Spent the rest of my career, as you said, here.
So was CDC, by visiting your college campus, your veterinarian school, were they actively trying to recruit veterinarians to CDC? They were.
And that was our effort to get out and introduce the program to students in their senior years of veterinary medicine. I suspect they were doing something similar at that for the medical schools, but many of the people in medical schools met people that had formerly graduated as EIS officers, so they got both sides. But I didn't know anything about CDC at that time.
So when you arrived at CDC as an EIS officer, how is it that you ended up in parasitic diseases?
There were really only 2 job openings for veterinarians at that time. One was in the zoonoses unit, headed up by Richard Parker. The other one was in parasitic diseases, headed up by Myron Schultz. And I was assigned to the parasitic diseases division.
And when you arrived, so this is 1970, how many, or maybe I should say, how few fellow veterinarians did you find here?
There were probably 3 or 4 other veterinarians at that time. I had a predecessor who was leaving as an EIS officer, and so I was his successor. But there were 2 or 3 other people that were in different divisions, and some of them were working as true veterinarians, but just a few of us as epidemiologists.
Yeah, it sounds like a small group. So you liked parasitic diseases, and hence they sent you on to London to get the master's level degree?
Yeah, we had a good run. When I was an EIS officer, got to do several outbreaks, one of which was echinococcus in Utah. Several patients had big liver infections with that organisms, and Irv Kagan, who was then the head of the parasitology laboratory, had developed a skin test for diagnosis, and so we were using that. It's kind of like a TB test. It's a delayed reaction. Read it the next day and how much swelling there was around the injection site. And so we found 30 or 40 cases of echinococcus in young children and adults in Utah. That's a disease transmitted mostly from dogs who eat the guts or offal from sheep and other ruminants.
So by sending you to London, I guess the deal was that you would come back to parasitic diseases after you got your master's degree.
That's correct.
Before we talk about AIDS, I wanted to see if you could give us a little bit of background about an activity that the Parasitic Disease Division was responsible for, the running of the Parasitic Disease Drug Service. And this, as you'll tell us, played an important role in the early recognition of unusual cases of Pneumocystis carinii. But again, it would be helpful to get some background, I think, about the drug service. So first of all, if you could tell us, what is the drug service and why was there a need for CDC to establish one?
Well, the drug service was established a few years before I came. The brainchild of Myron Schultz, my supervisor, and this, around 1966, 1967, Carl Western was his EIS officer, and Carl wrote up most of the INDs and put the stuff together. But it was done to be able to provide life-saving drugs for parasitic infections that were acquired by Americans who went abroad and came back. We had movie stars, we had Peace Corps volunteers, we had travelers, we had a variety of people coming back with various infections. The one that most people might recognize who have no background in parasitology would be African sleeping sickness, a disease caused by trypanosomes and the bite of the tsetse fly. And that happens to be one parasitic infection is also treated with pentamidine, the way pneumocystis is. Also, pentamidine was useful for leishmaniasis infection, so that was a key drug in our armamentarium. But for the African sleeping sickness and a few others, they were universally fatal if not treated. You would get the infection, and if there's no treatment available here, by the time you got to the hospital and had it diagnosed, you were fairly far along. So thinking about sending somebody to Europe to get the drugs was not a feasible option. So we explored ways to bring those drugs that were manufactured in Europe and used a lot in European population who traveled to Africa and India and so forth, got these infections. And the only mechanism that could be established was under the IND process, the investigational new drug process with FDA. Although these drugs were not truly investigational, they had well-established efficacy, well-established toxicity information. But again, we brought them in as investigational for the purpose of making them available in this this country. They were here also because there were so few patients to be treated that it was not economically feasible for any pharmaceutical company in the U.S. to sponsor them through the licensing process. At that time, that licensing process took about $2 million in several years to satisfy all the FDA requirements. They couldn't do that and make any money on 3 or 4 doses a year of drugs. So that's the basis of why the drug service was established. And we had probably 5 or 6 major drugs that we distributed at that time. Phentermine turned out to be one of the most common ones, largely because there was a shift in the late 60s and early 70s toward more aggressive treatment of cancers. And I'd say that most used of the drug was in children with various types of leukemia or other childhood cancers. Sent a lot of drugs to St. Jude, for example. We sent drugs to people that were receiving organ transplants and also immunosuppressed because of those drugs, and got pneumocystis. So I'd say probably throughout most of the 70s, we probably only averaged about 20 to 30 pneumocystis patients in that type of population a year. And then it started to grow in the early 1980s.
Was this arrangement with FDA, as you said, applying for an investigational new drug application, is this a pretty tedious process, and are there a lot of reporting requirements associated with it once the agency is holding this IND?
Yes, it's a very time investing process. The first process is writing the application itself. So a total research of the literature, writing down the safety and efficacy of the drug, where it's available, where we were going to get the drug, how it was manufactured there. And then the reporting requirements, well, the distribution requirements were first, and that is you had to have a parasitologically laboratory-confirmed case. We weren't doing on speculation that this person might have X or Y disease. They had to have laboratory-confirmed infections. And that was a help later on in the AIDS epidemic as well. We collected basic information: patient's name, age, sex, weight, diagnosis, underlying disease that was responsible for the pneumocystis, if it happened to be that sort of thing, or the parasitologic evidence of infection. This was done by EIS officers and myself probably for the first 8 years. The number of requests was relatively small. And then as we started getting more and more of the cancer patients with pneumocystis, the volume grew, the number of consults grew, and that time we hired a drug service technician who was Sandy Ford. That's been mentioned in some of the literature before. Sandy would take the initial phone calls, record the information about the patients, and then share that information with one of us, one of the medical officers or myself, to get an authorization to go ahead and release the drug. And that's the way it worked. She would then make arrangements for the drug to be shipped out. In the early days, it was relatively simple. We just packaged the drug, put it at the CDC front desk. A courier would pick it up and take it to the airport. On nights and weekends, myself and EIS officers, if we got the call, emergency call for a serious ill person, we would have to come in, package the drug ourselves, hand carry it down to the airport to Delta Dash, and have it sent off. And then the third variable was if the receiving hospital was not near an airport, then it had to be driven by taxi or somebody from the hospital to pick it up. And in many cases, the hospital was actually in a different state. And then we had to make arrangements with the state patrol to take it to the border, hand it off to another state patrol, and then get it to the patient's facility. So that was a very complex process.
A lot of links
in
this chain.
And a lot of effort, but you had a life-threatening infection in most cases. So
So time was of the essence to get this out.
Yeah, you wanted to get it there within 12 hours if we could, 6 to 12 hours.
So the drugs that you would be sending out obviously then were physically stored on the Clifton Road campus?
All of it was stored at the Clifton Road campus until we got into the AIDS epidemic.
And so I guess you'd have to have some sense of estimate the number of requests that you'd get, because then you would have to be importing drug from these European manufacturers and sort of keeping an inventory that would meet the needs as best you could estimate. Is that how it worked?
Exactly, that's the way it worked. For the pentamidine in particular, we got that from a London pharmaceutical company. They only made production runs about every 5 years, so we would estimate about how much we would need based on what we'd had before and order that amount. And when we needed about a year before we needed another supply, we would contact them and see when their next run was going to be and put in another order. I might say that became complicated as we got into the AIDS epidemic. We can discuss that now, or we can discuss it later.
Yeah, let's move into the AIDS epidemic, because you've outlined very well, I think, how the drug service worked, and it sounds like this was an EIS on-call sort of scenario, although obviously you were long past EIS, so you must have been backup call and things of that nature.
Yeah, we just rotated the calls initially,
see.
just take a week at a time, and all of us went through it.
So let's move to 1981, early 1981, and as you indicated, your typical request for pentamidine was a scenario of an immunocompromised patient, might have had cancer, whatever, and because of their immune-compromised state, developed these opportunistic infections like pneumocystis. So what started to happen? Some unusual things started to happen about the calls that came in requesting pentamidine.
Yes, it was very apparent. We're probably getting maybe one call every 2 weeks of a young, healthy male who had no underlying cause for their immunosuppression, no recognized underlying cause at that time. And so we're very suspicious about those initially, and really wanted to see some of the laboratory confirmations on a few of those, and they just kept increasing from one every 2 weeks to one a week. And Sandy Ford would bring these up, and we would discuss them, and she said, we've got quite a few of these now. And I said, well, let's go ahead and make a line listing like you do as an epidemiologist. Give us the age, sex, location, what the underlying disease was, and we'll see what we have there. So we had probably 10 or 15 of those at the time that the MMWR article came out. All of the patients in MMWR were on that list, but we had several from New York as well. So it's starting to be suspicious what was going on.
I'm assuming that Sandy, that you, the other physicians in your group, had a pretty good relationship with a lot of these hospitals, physicians, or even the laboratory staff, because as you said, you were requiring laboratory confirmation before sending out the drug. So were there any doubts in your mind that this was real? Were you able to talk with the physicians or the laboratory people on staff in the hospital and get their thoughts?
Well, we talked to a lot of them, and they were puzzled by it too. They said they just couldn't find an underlying cause, but they had several sputum samples that were positive by silvermethenamine stains, and that was as far as you could go. We were not going to withhold drug on somebody that's seriously ill. But what was really striking to me was some of the discussions about their blood oxygen levels. Some of these guys were down to 15 or 20, and that is, I didn't know you could live at that low oxygen levels. But they were seriously ill. And then
Would the pentamidine help them, or?
Yes, for a bit, but I think most of them were so ill, and you could not correct the immunosuppressive condition at all at that time. And most of those people had died probably within weeks of the infection. Whereas with some of the cancer patients and the organ transplant patients, we discussed with the physicians the possibility of throttling back on immunosuppressive drugs, let the patient recover a bit if they could as a balancing act. You fight the cancer or fight the pneumocystis, but I think most of those people would recover well with pentamidine use if you could modify the immunosuppression. Not so with the AIDS patients.
Now, there was another drug available, I think, that became available about 1974, trimethoprim sulfamethoxazole. And patients were also getting this drug as well?
Well, in the early days, there was only pentamidine. I don't remember when trimethoprim sulfa had been available for a long time, but only as an oral drug. These patients were too sick to receive any oral drugs. And so when the pharmaceutical company came up with a parenteral drug, an injectable drug, that was a big boon. But I think that was well after 83, 84, something in that range when that became available. And that certainly decreased the demand for pentamidine as a treatment in AIDS. And I think it became the first-line drug and also a prophylactic drug in some AIDS patients later on.
Oh, okay. So pentamidine really was the first-line drug of choice for patients in this early 1981 or
81, 82.
It was, okay.
Yeah, maybe 83.
Okay. And was pentamidine administered by the intravenous route?
Yes.
It was.
Yes.
Okay. Okay. So...
Well, it could be given IM as well, but actually most of it was given IM.
Oh, intramuscular.
Yeah.
That sounds painful.
Yeah, well, that's a pretty caustic drug. These anti-parasitic drugs are kind of like cancer drugs. They're kind of a contest of who dies first, the patient or the parasite, because you're killing cells that are healthy cells when you're trying to kill another beast inside of you.
Okay, so to go back a little bit to what you said, so you had Sandy and others, I guess, construct this line list. So this is before the MMWR came out. You had already started tabulating, if you will.
Yes, yes.
And was it just limited to that recent period of time, 1981?
Yeah, I don't think we ever saw an infection in a non-immunosuppressed person prior to 1981.
Okay, okay. So when you had this information, what did you do with it? I mean, this was unusual. I'm just curious, and it's before the MWR comes out. Was this then disseminated within CDC or to other people in your division?
I just went up the line as far as I give it to Myron Schultz, our supervisor. I assume he discussed it with Phil Brockman, the head of Bureau of Epidemiology at that time, because it wasn't long after that Jim and I, after the MMWR article came out, Jim Kern and I were summoned to the office of John Bennett, who was then the chief of bacterial diseases. And I didn't know Jim at that time. We both showed up at the office and we looked at each other and asked each other if we had any idea why we were here, and neither of us had a clue why we might be here, especially in bacterial diseases, because we didn't really, other than a few diarrheal outbreaks, we didn't have much in common in parasitic diseases. But at that time, John said, well, you're here because we want to find out if this phenomenon is real. If the San Francisco clustering and the clustering you've identified in the drug servers in New York, and we want you guys to go up and take a first-hand look and give us a sense of whether we really ought to pursue this more aggressively at CDC.
So this meeting in John Bennett's office is after or before the MMWR came out? Or maybe you can't remember.
I can't remember, but it's pretty close in timing.
Okay.
And we had one day to get ready to go up, so it was a really fast thing.
In terms of the MMWR, that came into CDC probably from the field officer in Los Angeles. Wayne Shandero had been working with Mike Gottlieb in LA about this publication. Was it did it come to parasitic diseases for the division's review of it, since it had to do with
It did.
pneumocystis?
It did, and I reviewed it, and it was quite good. They had most of the information there. We made a few editorial things, comments on the editorial comments, but they had it down well. They had the general concept captured, and just really not much question about. There was a phenomenon going on, and it needed to be further addressed.
Do you know if your division was the first one to receive it? I'm not sure what actually the chain of transmission would be, if you will, for a draft MMWR back in those days.
My guess is it came into Mike Gregg, who editor of the MMWR, and all of those things then get distributed back out to the respective branches that deal with that organism.
Okay, so that would make sense, absolutely. And then can you also just remind us about the organization of parasitic diseases, because obviously since the early 80s things have changed. So you were a division then, and then what were the layers above you, the organizational layers above?
The top layer was a Bureau of Epidemiology at that time, headed up by Phil Brockman.
Okay.
And below that were branches, bacterial diseases branch, parasitic diseases branch, family planning branch, a number of other viral diseases branch, zoonoses. And that's what was peculiar when we went into John Bennett's office, because we couldn't figure that out. And I didn't really ask at that time, but I can only surmise that maybe Phil Brockman was out of town, and he was acting director at that time of the Bureau, and that's why he was the one in charge.
That pulled you and Jim Curran together. Right. I see. Okay, well that's helpful. So parasitic was actually a branch that had not attained division status.
Yeah, there was no divisions in the Bureau of Epidemiology. That was a subsequent reorganization.
Now this is very interesting that the drug service, if you will, is instrumental in identifying an unusual cluster of cases or an increase in cases. Had that ever happened before, that by frequency of requests or patterns of requests for another organism, that the drug service, if you will, had almost served as a sentinel surveillance site?
There's one situation with malaria that came in through that mechanism, and it was what's called autochthonous transmission, transmitted in the United States rather than acquired abroad. And that investigation revealed that I think a returning serviceman had gone to a drive-in theater with the cars open, been bitten by mosquitoes, and bit several other people at that drive-in theater, and started a small cluster of 5 or 6 malaria cases in that time. That was an interesting concept.
Yeah, that is pretty quirky. Who knew a drive-in movie theater would be a risk factor for malaria? Oh gosh. All right, so we're a little bit off the track. So, so to get us back to the story then. So, you went to New York City. I think I still want to stay on the parasitic disease drug service bit. Well, maybe we should go to New York City because it's kind of chronological. So you and Jim, you said you went up the very next day after this meeting.
Yeah, it was fast. They wanted to make a decision where CDC should be going.
Okay. So what did you do? Who did you meet with?
We went to New York University Hospital. Linda Lobenstein was the oncologist there. She had about 6 or 7 patients with Kaposi's sarcoma. We met the patients, talked to them, see if they had any idea what was going on. They knew many other gay men who had pneumocystis, had other diseases, just to kind of get a superficial view if they had any ideas of where things were occurring. The other reason that, besides pneumocystis, the other reason I went along was because I'd talked to a Dr. Alvin Friedman-Kine, who was also at that hospital. Weeks earlier, because in the early stages of this epidemic, probably the most common presentation was a wasting disease and diarrhea. And at that hospital, they'd done stool exams on many of their patients and had found several parasitic infections, Giardia and E. histolytica. At that time, they didn't have a test for Cryptosporidium, but he was concerned because some of these patients just had chronic diarrhea and were wasting. They would have some that they would treat successfully and then come back 2 months later infected again. And so one of his theories was that maybe this immunosuppression is being caused by repeated bouts of frequent parasitic infections. And so I discussed that with him and said I didn't think it was very likely because people in the tropics deal with these things for a lifetime, repeated infections, and we didn't ever see any immunosuppressive events like this in those areas. But it was something he had seen and observed, and it was good we had a chance to discuss it. So again, we discussed some of those things up there, but it's mostly the Kaposi's and pneumocystis that was the primary concern.
Now, obviously, yes, you mentioned Kaposi sarcoma, and I was just curious, thinking back to your line listing that you, Sandy, and others had worked on in collecting information about these patients with pneumocystis. Had mention of Kaposi sarcoma come up, or was this a new one for you?
Brand new for me. I didn't see it in anything there. I don't know if any of those. I don't think those patients were ill enough, immunosuppressed enough to develop
Those that just had Kaposi's.
Yeah, just had Kaposi's at the time. I heard later that several of those people went on to develop pneumocystis, but I think at the stage that they were being diagnosed, they weren't that far along in their immunosuppression.
So you were going to visit patients, you interviewed or patients in hospital. What were your impressions? What was the clinical condition of a lot of these patients?
I think they were very sick, very weak, wasted. Almost even the Kaposi's patients were just super thin. It looked like they'd come out of concentration camps in Nazi Germany. Still concerned about their health, but still willing to help. That was the other thing I felt very strongly about, that these people know they're quite ill, and they were doing their best to give us information that might help, but they really didn't have a clue. We talked about some of their activities, the recreational drug use, the sexual contacts, travel, and each one of them had slightly different stories, and their friends had different stories, they said, so they weren't sure what was going on either, but it was there, and both Jim and I came away, this is a real phenomenon. These people are ill, and they're presenting with all sorts of diseases that represent some type of immunosuppression. And that's what we told John when we came back, John Bennett when we came back, and he said, well, we need to start moving on this. One of you guys is going to have to take the lead on this and get it started. And to me, it was a no-brainer. Jim was the best qualified person to do that because of his past history in dealing with sexually transmitted diseases. He was familiar with the systems and processes, and he took it on, and it was an excellent choice. He just had the right demeanor to handle both patients, the politics, and the medical community. I couldn't have picked a better person from my perspective.
When you were up in New York City with Jim for that first trip, I'm assuming you were up there for more than one day.
We were up there for just a couple days.
Just a couple days.
Because they had the patients at the hospital. They had them grouped there, and they had all the Kaposi's patients in one place and brought them down. So we were able to talk to them as a group in the amphitheater there.
Oh, they brought the patients.
Yeah.
They left. They had them move from their hospital room. Mm-hmm. Oh my goodness.
So it was a very efficient way to do it, and then we just talked with some of the other doctors there. And
so it sounds like you were seeing a lot of Kaposi's sarcoma patients.
Yeah.
Obviously, it would not have been possible to bring a very ill pneumocystis patient down to an auditorium.
Yeah, they could barely.
Oh, so was the focus then, a lot of the focus of the trip was on Kaposi's?
Kaposi's is because those people were mobile and could talk and freely discuss things. The other people were just, the pneumocystis ones were just too ill. I mean, they were on oxygen
Right.
high oxygen levels.
Did you go to see any of the pneumocystis patients?
We didn't. We
Just-
didn't.
Now, was there an effort made either by the physicians in New York City, Alvin Friedman Keene you mentioned, and Linda Lobenstein, or did you and Jim play a role in trying to document that these cases of Kaposi's sarcoma were unusual in terms of the age groups that were affected or the frequency? Was there any record review or anything that was done?
No, this wasn't really an epidemiologic investigation. It was more just a fact-finding trip to say, do we really want to, should CDC really invest and gear up and do something in regards to this? Is it a true epidemic on the make early on, or should we back off?
Okay.
And this is kind of our determination. We really ought to go ahead and start this process.
Now, you mentioned that after your trip, it sounds like the task force really started to become more formalized. Is that the right word?
Yeah, there was no task force prior to that. So I would say within a week, Jim had started arranging the group, bringing people in.
Were you part of that group?
No, I was not. I worked back in parasitic diseases. Harry Haverkos came to us as our EIS officer at that time, and he was quickly seconded to the group. And that's kind of the way I think a lot of the other divisions participated. They had their EIS officer, or some of their staff, maybe work in those areas for a while. And then the other major role was later on trying to identify the intestinal pathogens involved in the chronic diarrhea of these patients. So there was a great effort to bring stool specimens back to CDC and do a thorough exam, viral exam, bacterial exams, parasitic exams, fungal exams, put them through every process that we had to say, what are the bugs here, and are there any commonalities in that process? And that was a process that went on for a year or so, trying to collect the specimens.
Well, I was going to ask you, because you talked about during the New York City visit, meeting with Alvin Friedman Keene, and learning that a lot of these men had had repeated bouts of gastroenteritis related to Giardia and to amoeba. Was this something that you were aware of previously, because these are parasites? Was this something that, and did any of these other organisms, apart from pneumocystis, require drugs from the Parasitic Disease Drug Service?
No, but in retrospect, I know we talked to physicians in New York and San Francisco about parasitic infections, but there were commercially available drugs to treat those. Metronidazole was commercially available, Flagyl, if you will, and some of the other drugs for amoeba were available. So it didn't require the drug service intervention. It's more just a consult. How do we treat these people with E. histolytica cysts, as they were asymptomatic cyst passers, even before they got ill?
Yeah, because I was curious if, in addition, as I said, to your pentamidine requests, if there was anything else that was a little unusual that was coming to the attention of people in the parasitic disease branch vis-a-vis parasites that people were having. It sounds like pretty unrelenting infections that weren't.
Yeah, at the time, I think
usual.
we're getting through the drug service, I wasn't aware that they were repeated infections. I think that was the new clue that Friedman brought into the picture. When we checked the history of these patients probably in the late 70s, 79, 80, we were consulted on a number of infections in gay men, and that's also when we began to find out, well, some of these people did have international travel to tropical areas, and that's a high risk for some of these parasitic infections too. So that in itself was not too unusual then. If you go abroad, have poor sanitation, you're going to be likely to acquire some of these organisms. So that wasn't a red flag for us. It was this whole stuff about pneumocystis in healthy men that tipped the balance. All
right, so let's go back to pneumocystis then a bit, and pentamidine and the drug service. So remind me, you said before AIDS, on average, in any given year, how many requests was the drug service getting for pentamidine?
Probably in the neighborhood of 20 to 30 per year.
So then AIDS, that's 1981, 82, 83, what's happening in terms of frequency of requests?
I think probably by the end of 81, we were beginning to assess the need to make another purchase, and we did an inventory at that time and said, now with the increase in AIDS patients, we're running out of drug. We don't have enough drug to go 2 years for another run. And so that became a quasi-CDC emergency of how to deal with that. So we got back in touch with the drug company in London, and they said they did not plan to make another run for another 3 years. And so then we were really concerned about how we were going to provide enough drug. It so happens that in the previous purchase, we not only got the bottled drug, but they had an excess run of synthesized powder that they didn't bottle. And they asked us at that time if we wanted that powder, I think about 10 or 15 pounds of powder at almost no cost. So we said, sure, go ahead and send it with the drug. And we just had stored that in the freezer all that time. So when we got to this point, there's not going to be another drug run from the company we got it from. Plus, FDA had stepped in and said, well, if you're going to do this again, now we want one of our FDA inspectors to go over there and inspect the plant to make sure it's doing good manufacturing practices, as we do in the United States. But they were under no obligation to do that at all. They weren't selling drugs to pharmaceutical companies in the United States. It would be their gratis to do that. So another small wrinkle in the process. And then we began to focus on the powder we had left. And so the first step was say, well, is this proper purity? Now it's been sitting here for 3 or 4 years. So the CDC labs stepped in and said, we can do that. We can test for purity of this drug. And so they went ahead and did the purity test, and it was still 99% pure. We discussed that with FDA, and that was okay with them. Then it was a question of, well, we still have to find somebody that can process this powder back into an injectable drug. And that search went on for several months, and finally found a manufacturer in the United States, pharmaceutical company, that was willing to do that. And I cannot remember the name of that company, but anyway, they bottled it up. And then we had to write another IND because a different pharmaceutical company, different process, and finally got that idea approved. I think that came out in MWR store in 1983, where CDC was distributing pentamidine under IND XYZ. And then the following year, I think in 84, a commercially available source became available from abroad again. So they decided to go through the licensing process and get it commercially available in the United States, and we stepped out of the pentamidine business.
Wow, that's I haven't heard the details of that prior to this. Did you ever come close to running out? Was this kind of a race against time?
Oh, it was definitely a race against time. The numbers of cases were logarithmically increasing, and our supply was, I don't know, we probably had maybe 50 to 100 patient doses left at the time we had to rebottle the stuff, so we're getting pretty close.
Gosh.
And of course, at the same time, the cost of the drug logarithmically increased. So that was another, we weren't getting much support from Washington in terms of extra funding for CDC, so that had to come out of CDC coffers, cover the extra expense. When we started pentamidine distribution, the cost patient dose was about $5 for the drug itself. It probably cost another $30 to ship it through Delta Dash. I think when it ended up, the cost of drug was in the neighborhood of $600 to $800 a patient dose. That doesn't sound like much in in these days, but when you think of hundreds of patients, that was another $40, $50, $100,000 of expense that nobody was making up anywhere else.
But were patients charged for the drug when it was under IND?
No.
So these costs, first of all, the procurement, buying it from the company in England, and then in storing it and packaging it up and shipping it, not to mention personnel costs. You've got a drug technician, Sandy Ford, who's doing this as a job.
Yep.
So those were all costs that CDC had to absorb.
That's correct.
With no extra funding.
No extra funding.
And eventually it became $600 worth of resources.
Yeah, but plus the distribution. We didn't further talk about distribution, but that was another change as the volume increased. We had discussions with the CDC saying, well, is there a more efficient way to get this drug to the destinations? And that's when U.S. quarantine representatives at CDC chimed in and said, well, we stockpile some vaccines at the quarantine stations around the U.S. Port of entries. We could also stockpile this in our same refrigerators, and all we need is an authorization from you guys to release it where it needs to go. And so sometime around that 82 mark, we began stockpiling the drug at U.S. quarantine stations, mostly at the airports around the U.S., the major airports that had international flights in. And that got drug to people in just a few hours. That was a nice thing.
So the way this came about, did you, in Atlanta, did you start brainstorming this with the quarantine stations? Had somebody thought of this as a possibility? You made it sound like the quarantine stations volunteered.
Well, we had representatives here. John DeAgnes was one of them, and I think Joe Giordano had worked at for quarantine, I believe, but he was in the Bureau of Assistant Chief of the Bureau of Epidemiology. Between him and John and a couple other people, this just came up at an informal meeting. They said, well, I think we can do this. And so we got set up, and that was a good solution to the quicker distribution.
And there's a finite number of these quarantine stations.
They have almost all of them that receive international flights. So you had all the East Coast and West Coast places: New York City, San Francisco, L.A., Chicago, Denver. So you had a pretty good bunch. If you got an international flight direct in, then you had a quarantine station.
Okay. Given what you described in terms of the trials and tribulations of getting a manufacturer based in the United States to take the powder and, I'm obviously making it very simplistic, essentially mix it up with some sort of diluent, thank you,
Yep.
Searching for the word there. Were you relieved when pentamidine became available on the open market in the U.S.?
Well, it took a big burden off of us trying to get it out, and also by that mechanism, they could position it throughout their pharmaceutical range to make it more available to people. They could stockpile it at various hospitals. It wasn't any longer an emergency situation for the distribution part of it. It's still an emergency for treatment, but.
So obviously a better situation for patients and physicians,
yes.
Although the patients are probably going to have to pay for it now
Well,
or then.
Yeah, that's true.
So interesting thought, because this is happening, I think, about 1984, so 3 years or so after the initial recognition of an unusual occurrence. You had, I'm assuming the Parasitic Disease Drug Service was still keeping track of numbers of requests, obviously, and sort of the line list. I mean, had the pentamidine requests become sort of a surveillance system in itself that you could cross-check with case reports that were coming in through other channels?
I don't know how useful it was. I initially thought, working with Harry, that it might be very useful in terms of not only a surveillance tool, but getting back to people and doing investigations. But in fact, most of those patients had died soon after receiving the drug, so we weren't very successful in traceback. We had their names, we had the hospital, we had the doctors, but calling the doctors that these people had already passed. That's probably the saddest part of anybody participating in this investigation. You meet people, and 3 months later they're gone. It's just a very fast thing. So in terms of looking at reports to CDC, yes, it was useful for a short while, but as soon as the trimethoprim sulfa became available and commercially pentamidine became available, really nothing coming back, no request back to us.
Yeah, let me pick up on what you just said a little bit. From a personal perspective, for you, for Sandy, you're on the receiving end of a lot of calls from probably pretty desperate physicians. I mean, the clinical community was reeling with the impact of such seriously ill young patients. I'm just curious, what sort of impact did it have on you, Sandy, others in your group, from a personal perspective?
Well, I think from the volume of calls and consults, it certainly increased during the daytime. I think the hardest part was dealing with the after hours and weekend calls. So that put the burden totally on staff and EIS officers. We went from the guard calling us with a call to wearing beepers and getting called at 2 in the morning and getting up and going down the airport. It was a real struggle for quite some time. So people put a lot of effort into doing it, but again, we all felt this was life-saving stuff. It wasn't something that could wait 3 weeks and you could send it out. It's emergency response.
Yes, indeed. So all of that just sort of stopped once the drug
yes, and
became available.
That part was nice. But we had very few calls after that late at night. I mean, we still had the occasional African sleeping sickness, the occasional other thing, but back to one every 6 months.
I want to ask you about some other HIV-related parasitic pathogens, but before I do that, I did want to ask you, somewhere along the way, the organism name, Pneumocystis carinii, underwent a name change, and if I'm correct, I think it's now called Pneumocystis juravecii.
Juravecii.
Yeah. Can you explain why the name change?
Yes. We had the organism in our division because it was considered a parasitic disease, but it was a peculiar disease, and it only got pigeonholed in that category because it did not look like a bacteria under a microscope. It did not respond to antibiotics. Didn't look like a virus. It might have could have been a fungus, but it didn't respond to any of the antifungal drugs, and so by default, it got targeted as a parasitic disease, but it didn't have the classic morphology of a unicellular organism with organelles inside. And then later, with the advent of molecular biology, being able to test DNA of organisms, type them out, it was shown to be much more closely related to fungi than to any parasites, and thus the name change.
And when did that happen? And did it obviously within CDC get moved from parasitic diseases over to fungal diseases?
I think that molecular tool stuff really didn't develop until the 90s. So I think that was a rather late change and had very little effect on what we were doing with pneumocystis. We still consulted on it in the 90s by telephone calls, and so
I'm just thinking a bug that has been for decades been slotted into a certain division within CDC, and then because of these advances in immunologic or genetic testing is found to actually represent an entirely different class of organisms. And I'm thinking, that would be very difficult to move an organism, okay, no longer parasite, fungus, and to have another organizational entity within CDC to take responsibility without any of this background, decades worth of background and expertise.
Yeah, I don't.
Did that actually happen?
Not to my knowledge.
It's still within the parasitic diseases group.
Well, there really isn't a specific parasitic disease division now, I don't think. I think they're wrapped up in a broader group of diseases.
With one of the more recent organizations within CDC.
But certainly none of the people from fungal diseases came knocking on our door saying, we really want this organism. Especially in the days when it was a burden to carry it. But I don't think those DNA tests were available until quite recently. I would say I'm guessing probably in the late 90s, maybe early 2000s. We're just doing that sort of work with some of the other parasites in that decade, malaria and diagnostic stuff with DNA testing. So I don't think it affected the early pigeonholing of the organism.
Okay. Well, let's talk about some parasitic infections apart from pneumocystis. And you mentioned some in passing, Giardia, Entamoeba. So these were pathogens or opportunistic infections that were being seen in AIDS patients. And then you also talked about the very striking wasting syndrome, and that a lot of these patients had diarrhea. And you mentioned this very comprehensive effort to have stool specimens brought to CDC and put them through a lot of testing. What did this yield? Were there any new surprises, information about old pathogens that you gleaned as a result of the AIDS epidemic, or anything else?
Not really. From a parasitic point of view, I don't think there was any large grouping of organisms that would explain anything particular. I think the thing that I walked away with are two organisms later on that were recognized. One was a organism called Entamoeba dispar, and it was important, and this was a discovery made by Bill Petrie at Uniformed Services University back in the 90s. And he discovered that this organism was morphologically identical to E. histolytica, the pathogen that we were all dealing with from the tropics and other places, and had developed an immunodiagnostic test to differentiate it from E. histolytica. And that organism was found in several AIDS patients that he had looked at. And so I'm now thinking in retrospect that many of those repeated infections with reported as E. histolytica quasi-asymptomatic in patients back in the 70s and 80s were probably this organism, and we just could not make a distinction on morphological grounds. But we had this whole population of infections that were designated as asymptomatic cyst passers, passing E. histolytica cysts. Some of that had to do with AIDS. A lot of it didn't have anything to do with AIDS, just population in general, populations in orphanages and other facilities that took care of young children and forced sanitations type things. And we actually used that test on a waterborne outbreak of amoebiasis in Tbilisi, Georgia, trying to make sure that what we were seeing in patients there was really E. histolytica and not dispar. And ours turned out to be E. histolytica, and they had liver abscesses and everything else associated with that outbreak. But it was a new concept that you could have an organism that's morphologically identical to isolate and not be a pathogen. He had seen this many times in Central and South America when they were doing studies down there. The other organism that cropped up on the screen is Cryptosporidium, and I think that's an important story to tell. If it had not been for the AIDS outbreak, we would have never known that Cryptosporidium could be a human pathogen. I think that's one important point to make. We knew probably in the 60s that Cryptosporidium was an important cause of diarrhea in calves in the veterinary world. And a lot of activity done to try to control it in dairy herds, dairy calves, and so forth. But until the AIDS epidemic came along, didn't think of it as a human pathogen, and for a while just thought it was one of those opportunistic infections again in immunosuppressed individuals, because that's what it was seen. Then a microbiologist by the name of Pearl Mall at New York University developed a modified acid-fast test. It was a great improvement over the old one. It required a lot of heat and a lot of extra work. I began using that test AIDS patients at their hospital. And 1 week, for about a 2-3 week period, they were having an outbreak of diarrhea in the hospital's daycare center. Staff would be able to bring their children in and leave them there and have good care services. And they'd look for all sorts of bacteria and viruses, the usual suspects that might be responsible for that, and just weren't finding anything. She decided one day, well, I'll just try this acid-fast test and see what comes up. And several of these children had Cryptosporidium. And they weren't immunosuppressed at all. It just first kind of recognition that this could be in a healthy individual and cause chronic disease. And from that point on, people began using that test, including us at CDC. And probably within 6 months of that occasion, we started investigating several diarrheal outbreaks in daycare centers in the Atlanta area and found Cryptosporidium. Then it became a big question, well, how do you control this sort of thing? And usually you would wait till they cleared the parasite, would be your recommendation. So, well, we don't know how long this parasite stays around. So we began doing stool tests on children that were left out of the daycare center, saying, okay, before you return this to stool negative ×3, and make sure that they're free before they go back in. And when we did that, we found out these kids would still be passing oocysts occasionally 30 days out, 40 days out. And so we had to change our public health policy about, well, we have to think about something other than that, because what these parents were doing, if they couldn't get back in their daycare center, they'd put them in another daycare center and start the problem all over again. So it became a public health policy from that to simply wait till the diarrhea had disappeared, and caution management to be very careful in diaper changing in those facilities to keep the kids separated as much as you could. But the other phenomenon that occurred at the same time, in 1986, we had a waterborne outbreak of Cryptosporidium in Carrollton, Georgia, just west of here, 70 miles. And that was initially responded to by the bacterial diseases folks, or viral diseases folks, because it presented with diarrhea, low-grade fever, some nausea and vomiting, and they were working it up and weren't finding much. But we'd already made agreements between the viral, bacterial, and parasitic diseases group. When an officer went out to field, we would all back each other up with laboratories tests to make sure we were doing the right organ. Well, the specimens came back to us, and it was just loaded with Cryptosporidium. And this is a story that then launched into waterborne cryptosporidiosis, then recreational water, Cryptosporidium, whitewater in Georgia had a big outbreak with kids in the swimming pools and people getting infected. And the common theme here is why all this water stuff, or why the daycare center stuff, and that boils down to this issue, which is disinfection. And they all have in common that they use chlorine dilute chlorine for disinfection. The water industry, drinking water industry uses this. The swimming pool people use this, and in daycare centers they squirt down the changing tables. The concentration used in water, drinking water and recreational water, and in the changing table is about 1 to 3 milligrams per liter of chlorine. This contains 50,000 milligrams per liter. And when researchers want to do infection studies in animals, they soak the Cryptosporidium in there to kill off all the bacteria, fungus, and stuff, and the oocysts are still infectious. That told us that disinfection, as we were practicing it now, both for community drinking water, for swimming pools, was not going to touch that organism. So it opened a whole new door of changing regulations and processes in the United States for dealing with waterborne disease and water treatment, all based on what was evolved out of the AIDS outbreak.
So that's quite a story. I mean, that's quite a story that in the context of the AIDS epidemic, a pathogen that had not really been on the scene or recognized becomes one of the opportunistic infections that cases of AIDS are getting. And because they're immunocompromised, they're clearly not able to clear it. Mm-hmm. Or really, for a lot of them, their GI symptoms persisted. Mm-hmm. I mean, this was part of the wasting syndrome complex. But then it leads you into all sorts of other populations, risk group, factors associated with the infection. And now what you're saying is there's not really an effective way to treat water, infected water, let's say, or...
Well, there is. It changed the regulations in a way a lot of people operate. For the daycare centers, hydrogen peroxide is a more effective thing. But we learned you just can't squirt it on the table and wipe it off like you would do in the exam room. You got to leave it on there, have a little contact time, maybe for several minutes before it's really clean. Kills the organisms. In the drinking water industry, there's 2 layers of treatment. One is the filtration part, and one is the disinfection part. And in the filtration part, we found that this organism was getting through the filters, as would some bacteria and viruses. But if the bacteria and viruses got through, you had the disinfection waiting for it to finish it off, so it wasn't a big deal. For Cryptosporidium got through there was no safeguard left. So the bigger utilities have moved on to either UV radiation of the finished water, which is highly effective against Cryptosporidium, or a process of membrane filtration with reverse osmosis. And that also, very membrane filters, would actually remove the organism. And EPA had to change their filtration guidelines. It's how well the water's filtered is measured by turbidity units, how much turbidity is coming through the water after treatment. Start with a Chattahoochee that's red and muddy, and you come out with clear water, but there's different levels of turbidity there. So the smaller utilities were often just barely meeting the EPA standards. The bigger utilities had qualified engineers trained to manage that much more effectively, and they would get the water turbidity down, filtration down, probably 10 times better than EPA required, sometimes 30 times better than EPA required. So EPA then eventually had to say, okay, we got to change our filtration regulations, and we got to start thinking about better disinfection. And then they also had to start thinking about sewage discharge into the rivers, because people were boating and playing in those rivers and streams around the country, and that's still an issue that has to be addressed effectively.
Is there treatment for cryptosporidiosis infection?
There are. Netazidazole, I think, is the drug that was. Maybe it's narizazole. I can't remember what it's the N word.
But obviously, the key is prevention through
The key
the
is
methods
prevention.
you've described in terms of water
The problem is that
filtration.
the problem is with treatment in the healthy individual, otherwise healthy individual, is that you'd have to probably do it at the first sign of diarrhea. It's like a common cold. It's going to be self-limiting. In 7 to 10 days, most people are going to get well and they're going to get over it. So you wouldn't probably use this unless there was some reason to intervene very early to shorten the course of diarrhea. But most people are going to self-cure. And that's probably why we didn't recognize this years earlier. You might have had waterborne disease forever, but diarrhea is such a common thing. Say in the office, physicians say, well, I don't know what it is. It might be some virus going around. But you could have hundreds of thousands of people infected that way.
That is a very interesting story. Just let me tie up a few things here. So when I asked you a little while ago about further involvement with the task force after your initial visit to New York City with Jim Current, you mentioned not really. You mentioned your EIS officer, Harry Haverkos, was involved in work related to the task force. But I'm thinking that you had to have some sort of peripheral involvement with the ongoing epidemic, given your subject matter expertise in parasitic diseases and the development of guidelines about treatment of these diseases and whatever. So is that fair to say that you did have?
Well, we had informal discussion. I don't think I ever attended a formal task force meeting, but the questions that came up in that period of time, both with physicians at hospitals and with Harry and a few other people. What do you do when you have 5 patients with pneumocystis in your hospital? Do you do respiratory isolation? Do you leave them in the same room? Can you put somebody with pneumocystis in a room with AIDS patient that doesn't have pneumocystis? And it became a very difficult problem for most hospitals how to bed these individuals safely. And there's always some concern about respiratory transmission of pneumocystis to somebody that didn't have it. And we really didn't understand the true epidemiology of pneumocystis at that time. I'm not sure we still have a great handle on it, but there have been efforts in animal models to use nude mice, immunocompromised nude mice, infect some with pneumocystis. You could do that with droplet inhalation or nose. Put them in cages upstream of a stream of air, and put healthy individuals downstream to see if you get respiratory transmission. Just not able to do that. It just didn't seem to work. But yet, I said, I would, if I was an AIDS patient without pneumocystis, I wouldn't want to be in a room with somebody that did have it. It just doesn't make any epidemiologic sense or medical sense to me if you have to have the space to accommodate them. Then later on, with molecular DNA analysis, there was some papers that suggested there might be respiratory transmission in hospitals, but still not very sure. At the time we were doing this, I was thinking that this is probably, like many fungi, it might be environmentally common all over the place. We all might be exposed to it from time to time, but with the intact immune systems, we're fine. If you happen to get immunosuppressed and you have that in your lungs, you might then develop disease. But the molecular tools are starting to tease that out a little bit, so maybe there is some evidence of direct transmission.
So it sounds like, while you may not have been a formal member of the task force, and clearly over the ensuing decades, 10, 20 years, your expertise in parasitic diseases was still something that was very much helpful in consultations related to, be it infection control or treatment or prevention guidance.
Yeah, we talked about, we haven't talked about toxoplasma, but that's another one that came up occasionally, and how to manage those things. But it was an epidemic that involved everybody's time and attention, a lot of it directly in the task force and going right out and dealing with patients in all the states, but there's a lot of background work still being done at CDC between the patient interfaces.
So AIDS actually was a part of your extensive career at CDC, but obviously your career at CDC included quite a diverse range of pathogens and problems and whatever. I'm curious, given that you had that intense early experience and then maybe some ongoing intermittent consultations related to issues that cropped up about AIDS, did it nonetheless have any sort of lasting impact on you those early days? Were there, do you think back to them and anything else comparable that came up in your career?
Oh, nothing comparable. I think it was the epidemic of the second half of the 20th century. Without a doubt, it was career defining for many people at CDC. But even if it wasn't part of your career endeavors, there were very few people that weren't touched in some way by this epidemic. Doesn't matter if you were in the lab or you were a secretary, you were doing something sometime, budgeting something, administratively working on something that had to do with AIDS. It was an all-hands epidemic. You got seconded to do this or that, and what was amazing to me is nobody complained. People said, yes, this is real. We're going to contribute our part, what we can to it, and go on.
Well, this has been very interesting chatting with you, Dennis. Thank you so much. Any closing thoughts, anything that we haven't covered?
Not really. I think the only thing that did strike me, and it really had a lasting effect, was in the early days at American Society of Tropical Medicine meeting. Can't remember which city it was in, but Jim was speaking there as well as Anthony Fauci and a lot of other AIDS researchers. And we just got started in the program, and the program got disrupted by ACT UP folks. Came in and kind of disturbed the whole process. And this is kind of my first exposure to that type of activity, and now in retrospect I can see why they were upset, because the government was just ignoring it, wouldn't speak about it politically. None of the congressmen would ever say the words, none of the presidents would. But it struck me as really sad, because I knew all those people in that room were working their ass off to try to help them, and they were disrupting that discourse. So that left a negative taste in my mouth for that activity, and it wasn't until later on that I came to understand why they were frustrated. But they happened to hit the wrong group. There's no they aimed their comments at the wrong group, because everybody there was pretty seriously trying to help. And that was also my first foray into realizing how politics influence public health, and it was a really difficult time in the beginning to get any political support, any funding for the AIDS outbreak, and I thought that was extremely sad, given the amount of effort that people were putting into this on their own funds.
Well, Dennis, as I said, it's been a real pleasure chatting with you. Thank you so much for coming and talking with us this morning.
Thank you. I enjoyed it. Thank you.